all enjoying and absorbing all the information that you have been offered through Pallium. And today, as I've been telling, you've got an interesting session because all of you had queries. How am I going to tell it? What should I do? What should I not do? What should I say? What should I not say? How should I say? These have been the queries in all of you. So to ease and put us right and know what has to be done, for that we have got someone to take us through. With this, I welcome Ms. Mukta Dhavalikar to take us through our session. She has obtained her master's MPhil in clinical psychology from Amrita Institute of Medical Sciences, Kochi. And she runs her own practice and also a consultant psychologist at the Dilasa Center for Palliative Care for the last 3 years. With that, I hand it over to you, Ms. Mukta, to take us through communication, what's essential for all of us.
Hello, am I audible?
Yes, ma'am.
Yes. Trying to share my PPT. Also, in case I'm not audible in between, please let me know because I'm in Goa right now. We have a red alert. So there is a lot of, there are extreme rains going on. So in case there is any network issue, please let me know.
Radha ma'am, you are muted.
I said, Mukta, you just go ahead. What we generally will do is, you go ahead and do any disturbance or anything. We will even, in fact, get in touch with you. Don't worry. Okay, you go ahead and start sharing your presentation.
Okay, ma'am. Yes.
Or if you have any difficulties also, we can do the sharing of presentation from Parliament also.
Yes. I think...
will that be better off?
I didn't catch the name of our support person from Pallium who's there today. So do you have my PPT with you?
Yes, ma'am, we can share it across.
Oh, yes. There, Sripriya is raising her voice too.
Yes.
Go ahead and share from.
Why is it important according?
Yes, any of you can either unmute and speak or type in the chat. Why do we need communication session? Is that what she's asking? They all had so many queries, but everyone is so silent, Mukta, today. Oh, all cheer up. And what you were asking me, you can ask her straight away now.
Yeah, and please communicate. Let's not let this not be a one-way communication.
Yeah, I'm Dr. Sarupa.
Yes, go ahead, please.
Yeah. The communication is very important because how much ever we find the diagnosis or we're going to this thing, it's how we communicate with the patient that's very important for us for the to carry out the treatment as well as the management plan for the patient. So I feel the communication is the utmost important thing in our treatment plan.
Exactly. What you may have something in store, but how am I going to deliver it? And it has to be delivered appropriately. Otherwise, it can fire back. So we don't want anything like that. We want a smooth sail. Okay? Very good. Thank you very much.
Extremely sorry to interrupt. Mukta ma'am, actually, we have not received the mail cleanups. I will confirm if you have
okay. Just a second. Let me just try and resend it to you.
to tips acquired by immediate to watching.
Ma'am, your voice also breaks, ma'am. It's not very clear
Hmm.
sometimes.
Yes, your voice, Mukta, what happens? Sometimes it's okay, sometimes it does break. That is why maybe if
Oh,
Pallium shares the presentation and maybe
yeah,
you
yeah.
can have your video off and speak, then the quality will be
Yes,
good. Already you've got your video off. Continue and try
yes,
to,
yes.
I hope
Yes,
you
yes.
are using
Actually, that's
hands-free.
the thing, ma'am. Actually, yeah. No, it's because of the rains that, like sudden rains we have got. Yeah. Okay. I also want all of you to just forget for a moment that you all are doctors and think back to your childhoods and tell me one good memory of meeting a healthcare practitioner that you have, or one bad memory that you have with a healthcare professional. Anything would do. When you were smaller, when you had nothing to do with the medical profession. Anyone? Does anybody have a good memory or a bad memory with a doctor?
Either way is good. Bad means don't think I shouldn't say. Anything you can speak. This is a platform where you have full freedom.
Anyone?
Can I?
If not, I'll just go ahead because anyone, yeah. Hello?
Someone, I think, they said, can I speak? Please go ahead. Whoever wanted to say.
Yeah. Good evening, ma'am. Should I just raise my hand also? I had a good memory about the doctor. That is the reason that I chose this profession. So the doctor was he greeted my parents in a very nice way, and he was like very receptive to their problems. That is the reason I chose this profession. This is a good memory that the way he did and the way he listened very carefully, that helped me a lot. I thought that this medical profession is a very nice profession. And the bad memory, I remember that once I went to gynecologist, that she was so pissed up with her work herself only. The moment my relative and I entered the room, she was like, I should commit suicide and I'm leaving this profession. So there were two contrast things which happened. So like the good memory is that stayed for a long time was the nice gesture of the doctor that he showed to me. She was a physician and he behaved very nicely with my parents. And that really helped me in my profession. Thank you.
Thank
How
you.
old were you, if
Thank
you
you
don't
so
mind?
much.
Yeah.
How old were you when you had the nice one and the not nice
Yes,
one?
ma'am, I was in 9th standard, and mother had an acute gastroenteritis, and I went to meet that physician, and he was very nice. He was a very kind fellow. And this one, the gynecologist, I was doing my MBBS, and during that time I met. The bad memory was later when I joined the profession.
Thank you very much.
Thank you, ma'am.
Thank you. Thank you. Yes. So basically, if we all look back, even if we are not sharing, generally good memories are with doctors who looked at us as fellow human beings, who spoke to us with genuine care and concern and respect, who did not treat us from a high chair looking down upon us. And it's not also just about being in a patient's good books. It is also about a lot of other things. It is about treatment adherence. It is about the patient's need and right to know about their condition, to have clarity about treatment options, about prognosis, about the professional being accessible to openly asking doubts. Right? And studies indicate that there is a major unmet communication need for information about the disease, information about prognosis and treatment options, side effects, and complications. Basically, what this tells us is we avoid difficult conversations. Right? Next slide, please. Right. So what does good clinical communication really do? What does it enable? First of all, it enables the patients to express their needs easily and efficiently. It helps clarify doubts and baseless assumptions, right? I need to know what my patient needs. I can't assume on their part what they actually want. Secondly, it helps us build rapport, which ultimately aids in treatment adherence. It helps the patients and the families deal better with their emotional responses to the illness and the uncertainty. Thirdly, it enables us to better understand the symptoms. How are they changing? How is that change impacting the patient's quality of life? Simply put, we start seeing clearly exactly where the patient stands physically, mentally, emotionally, spiritually. It brings clarity to the clinical condition. And that can help us better understand the patient's thought processes, the meaning that the patient attaches to his or her situation. Through good communication, the physician can convey the required information about the disease or plan of care to the patient in a manner which helps him or her feel supported, right? Next, definitely, we need long-term clinical relationships many a times, especially when we're dealing with long-term degenerative diseases and such. And these long-term clinical relationships are sustained on trust, and communication helps build that trust. You already know that the patient, their family, and members of the treating team are all equal participants in the treatment process when we talk of the palliative care setting. So when there is mutual trust among members of this team, that definitely encourages rational and shared decisions about treatment. And we can basically reach a more balanced decision making, right? And that is when the patient is more likely to come with therapeutic planners and to adopt health promoting behaviors. So when I say a balanced decision will evolve, what I mean is a decision that is based on the patient's values, the patient's beliefs and priorities, yet is also supported by clinical evidence and clinical rationale. So we are not taking the decision for them. It's not unilateral, right? So coincidentally, I was also like recently I started dealing with a case of kidney failure. Okay. Anup, next slide, please. Yeah. And the crux of this case has been communication so far, right? So nothing better to illustrate how communication is an essential component of our work. So this person, let's call her S. She is a 37-year-old lady living in a nuclear family. She is educated up to 10th standard. And she, with her husband and her 11-year-old son, they live on a farm. Her husband works there as a caretaker of that farm. Now, she's unable to understand English. She follows Hindi, but not very fluent at it. She speaks Konkani, which is the native language. Given their socio-economic condition, the lack of literacy, lack of exposure to cities and urban setups in general, the husband is also hesitant when it comes to big institutions, big hospitals, where he feels he won't be entertained, or he will ask obvious questions and end up looking like a fool, or he won't understand what the doctor is telling him anyways. And they've also never had to go to such a place either, because both of them were quite fit until now. Whatever little health issues, minor ones they've had so far, they have managed with the PHC, the primary health center, which is there in their village. Now, out of the blue, this lady was diagnosed with a shocking case of kidney failure, the reason being unclear. When she went to the PHC with complaints of tiredness, swelling of feet, they urgently sent her to the big government hospital in the capital city, which is around 3 hours from their place, 3.5 hours. Now, the doctors at the PHC did not want to deliver the news, so they kept mum. But they asked her to rush and to do these tests urgently. They never said why or for what. Okay, now what happened was, now coincidentally, luckily enough, the owner of that farm, this person's boss, he was concerned and he took matters in his own hand, and he accompanied them to a specialist who did not speak the regional language. Now, whatever he spoke was either in English or Hindi and directed at that patient's boss, because he would understand. And the husband, who was anyways intimidated by the setup and the doctor and the reports, started pushing the boss ahead whenever it was time for discussion with the doctor, assuming that if he goes on himself, he would not understand, or he might misunderstand, or he might panic. And the patient herself was not told anything about the diagnosis except that her kidney wasn't functioning properly. Her treatment began, but there were no results. Now, when they went to the doctor with the reports for a follow-up, he just turned to the couple and he said curtly that they should get her parents for organ donation. Next time जब आओगे, parents को लेके आना, उनको kidney देना पड़ेगा. The patient found this to be very rude and very insensitive. She refused to visit him again and she stopped taking the medicines completely. So then what happened was she was taken to a different doctor who would also not communicate directly with her, but at least was not rude. Now the husband, with his prime defense mechanism of avoidance, he got her everything. Okay, he got her medicines, the good food, fruits, vegetables, everything, but he never spoke to her about her illness. Except the one exception when he actually did speak about the illness was when he got angry at her that she wasn't taking her medicines properly. That was his only complaint. And that is the only time he spoke about that illness. He also complained about the same thing, that his wife is not taking medicines properly, to his boss, the owner of that farm, who contacted me then for a consultation. Now, based on what we know of S, do we all agree that what was happening till now was poor communication? And if we agree, why do you think so? Why do you think that this was a case of poor communication? Anyone? Do we agree that there was lack of respect?
Communication.
Yes, I think somebody has raised their hand.
Lack of communication. Yes.
I think the way the interaction, whatever we could follow,
Right.
the courteousness is totally not. That's all. I think the first and foremost, the courteousness of in the interaction between the doctor and the patient has to be there. So that's where you bring build up a rapport and you give confidence to the patient. That I can express myself with this gentleman or whoever it is, so that they can listen to me and I can feel more comfortable in discussing with them. More than the medical issues, it's at the first instance, it should be where the individual gets confidence in you. That's what I feel.
Right, absolutely. We also have some answers in chat which are also like very apt, very true, that the patient also needs to know, they have a right to know what is happening. So nothing was explained. There was no respect, no courteousness from the doctor. There was also avoiding the topic at home. So within the family also the communication was lacking. And what were the consequences of this? So next slide, please. Next one. Yeah. So in general, what could be the consequences of poor communication? Not just in this case, but in any case. It may lead to poor symptom control. Patient may not comply with the plan of care because the patient's needs, patient's concerns and their agendas have not been discussed, have not been addressed. The patient might not even know what they are taking these medications for. And of course, there is this would that adjustment to this and to the interventions before, which would lead to a worsening of distress. Conflicts can escalate, right? So here, as we saw, the patient found the doctor rude. Her husband got angry at her for not taking medication. So we start having conflict. Then these conflicts start escalating as we progress. And a team that does not communicate effectively may find an inquiring patient as too demanding. This can also impact the therapeutic relationship, of course. Probably if the patient would have somehow got the courage to actually ask questions, given how the doctor behaved, he might not have, he might just have been, dismissive of her concern. And also, some of you also have experienced this in like whichever setups work. Medico-legal problems stem primarily from poor communication and misperceptions and misunderstandings that ensue out of that. Right. So we saw a lot of those things in this particular case as well. Right. So basically, now we know that something positive comes out of good communication, and there are negative consequences of poor communication. Right. Next, please. Also, for lack of time, I'm just running a little bit. If it becomes too fast, please let me know. So, of course, there are some people who feel that they are good communicators because they're quite sociable and they like to talk. Yeah, but do you think that's enough? Just being able to hold conversations is not necessarily good communication, right? One-sided communication is not good communication. And just being gentle is also not good communication. So we also need to know what is not communication skill in the first place. Right? So as I said, conversation is necessarily adequate communication. Good conversations on general topics, travel, politics, weather is not adequate communication. Secondly, somebody who is very good at convincing is not necessarily a good communicator. Trying to convince the patient to follow an agenda that is decided unilaterally by the clinical team is not good communication. Thirdly, just conversing in a soothing and gentle manner, but not allowing for the patient's participation again is not good communication. Or conversing in a soothing and gentle manner, but not being really honest with what you're telling, again, is not very good communication. As professionals, one very, very important thing that we need to understand is communication skills are not inborn. News is we can all learn and we can keep getting better at it. And yet we don't. Why is that? What stops us and what stops our patients from being communicating with each other? Let's look at that. Next slide, please. So there are, of course, possible barriers that hinder us as professionals. This is something that we can all relate to. We would have all times when we felt this, that we are too busy to spend time to understand thoughts and feelings of patients. We would be sometimes worried about upsetting the patient and handling the reactions that come. So we just try to soothe and keep them calm. We might feel like we don't really have the knowledge and the skill that's required to deal with this. So that makes us feel uncomfortable to enter into this unpracticed area of interaction. Sometimes we don't know, we are not able to say, I don't know. Yeah, and that also hinders communication. We feel like we should know everything about this particular condition this patient's having and what cannot happen and all of that. But that's not practically possible so many times. Also, sometimes what happens is, as doctors, it's easier to answer medical concerns, much easier to do. Might not perceive communication as a part of our jobs. We might be worried about being blamed, or we might fear that just by talking about this, we might just worsen the situation. The patient might get aggressive, the family might get aggressive or something like that. And of course, a very, very practical difficulty is unfamiliarity with the language and the dialect. And this can become a big barrier. So that is why we don't communicate at times. So why doesn't the patient communicate? Next slide. So what are the patient's barriers that they face? Of course, the physician is perceived as too busy, especially in settings like oncology. There is lack of privacy and unfamiliarity with the surroundings in bigger hospitals many a times. There is a perception that patients hold that only physical problems are to be conveyed, right? And this is a very, very common thing. There is, of course, the fear of confirmation of bad news. Many of them have an inkling that something is wrong. They just don't want to hear it being confirmed from the doctor's mouth. There is fear of treatment being denied if they raise questions or doubts. There is a fear of losing control over emotions. having a breakdown. They might be stumped by the medical jargon, the technical terms, and of course, the authoritative hierarchy of the hospital environment. It's not very easy. Like most of the times, people who can answer their questions are not easily accessible.
Do you mind putting
Right.
in the chat what country you're going to be in, or what time zone you're going to be in for the course duration, or if you've got any periods of travel? So then I thought I could just capture the people who are here today in the meeting, and then that's going to help with
Priya,
arranging.
can you please mute this person?
things. Thank you.
Hello.
Sorry, Mukta, it was some of the
No,
participant, I think.
Yeah, it's okay. It's okay. Yeah. Okay, all right. So, yeah, we were speaking about the barriers. That I also have noticed that so many of these patient barriers were present in the patient that I spoke about also. And if you're wondering why we're speaking of barriers to communication rather than communication skills themselves, it is important for us to identify these barriers, because only then can we rectify them. And if you're not able to do that, however many skills we might learn, we would still not be able to have good clinical communication. It's the barriers before the skills, right? So finally, the changes are these communication skills. Next slide. Yes. Communication, as we all know, is acknowledging and understanding the patient and family, and responding in the most appropriate manner to bring clarity to their current situation. So basically, what do? We hear, we take in information, verbal and non-verbal. We are actively, mindfully present and receptive of it. And then we also respond appropriately, again, verbally and non-verbally. I have here on my slide what we may call as the core principles of good clinical communication. You might notice that it really has very little to do with your language usage and very much to do with being a good human being. And that is the prerequisite, if I may say so. So firstly, there is, of course, treat the patient and family with respect. This is essential for a healthy relationship. Secondly, have empathy. We all know that empathy is the ability to try to understand the person's feelings by placing ourselves in their shoes. It helps to acknowledge the other person's suffering. It helps to build a good relationship. It is very different from sympathy. Again, most of us would already know this. Sympathy is a sense of pity that the other person may find offensive. Thirdly, there is trust, of course. Once a patient has lost trust in you, you lose the ability to help him or her. Truth is essential for maintaining trust. Lies, for example, an effort to conceal the diagnosis or something, would, of course, destroy trust. And lastly, unconditional positive regard. We have no right to be mental, whether the patient is thankful or grumbling, optimistic or pessimistic. We should try to consider him or her as the most important person in the room. In particular, care is needed to not come to a position of taking sides. If there are rifts with family, particularly between a patient and a relative, conditionally positive regard is when we something in return of something, right? So I'm concerned and I'll smile at you and I'll be very good at you. And all of that, I'll speak very gently with you and very kindly with you. If you're, nicely taking all the medicines that I've given without any complaining or grumbling, that is conditional positive regard. Unconditional positive regard is, I'm your doctor and I care for you regardless of how you behave. Right? So that is unconditional positive regard. Let's just have a quick quiz. Next slide, please. Okay. So let's say my patient says, I feel really scared and I can't sleep. There are so many thoughts, right? Very scary thoughts, and then I can't sleep. Which of these responses reflects the core principles of good clinical communication? What do you think? The first response is, you must not be taking the sleeping pills, isn't it? Second is, oh, don't worry, it'll be all right. Third is, for you, how did this happen to you at such a young age? And third, it must be so difficult to relax with all these scary thoughts running in your head. Which of these, according to you, is good clinical communication? Anyone? I think some people are saying, oh, a lot of people are saying B. Okay. Anybody with a different answer? Somebody says B or D. All right. All right. Okay. Fine. Let me tell you, the answer is D. And I think it'll be clearer why it is D as we go ahead. If it's still not clear by the end of the presentation, please ask me. All right. So let's move a little further into the nitty-gritties of communication. Next slide, please. Right. So we all know that there are two types of communication. There is verbal, there is non-verbal. Verbal is basically all that is expressed using language, and non-verbal is facial expressions, body language, gestures, etc. Right? And we all know that communication occurs verbally and verbally, but what we are unaware of is that communication accounts for the bulk of our daily communication. Sometimes it can be the sole means of communication in young children and in people who are terminally ill, differently abled, or emotionally overwhelmed. And when I say young children, I don't just mean children who are unable to talk, but also children who can speak properly but don't have the vocabulary to express what they feel. And in all these cases, we rely more on nonverbal. In general, also, we trust nonverbal communication more than we trust verbal communication, right? So let's say, for example, somebody says hi with a smile versus somebody says hi with a frown. When would you feel more welcome? Or when would you feel like the person actually means what he's saying? When the person is saying hi with a smile, right? So if there is basically, what I mean to say is, if there is a discrepancy in verbal and non-verbal, we trust what is not said. Yeah, so it is extremely important for us to pay attention to the non-verbal cues that we get while talking to patients, and we need to respond to the unsaid as well. Right? So let's say, for example, hello. Okay, yeah. So let's say, for example, a patient is looking gloomy, okay, and during rounds, and them how they're doing, yes, I'm fine, okay. You need to acknowledge that although they said, yes, I'm fine, they do look low and down today. Let the patient know that you care enough to notice. Just like we speak about the patient's non-verbal communication, we are also communicating through our gestures, postures, how we sit, the tone of our speech. So we need to be aware of what messages we are sending to our patients, right? Let's say, for example, I'm sitting in front of a patient who's crying, and here I am thinking, oh, now I'm going to be late for my kid's school function, and I discreetly check the watch, and I'm sitting, but I'm very restless and fidgety, thinking of how I'm getting late. Will the patient notice? Do you think that will create a block in communication? There are simple things about our body language that will facilitate or hinder communication. Yes? Next slide, please. Okay, yeah. And when I say there are simple things, very simple things, a genuine smile, an open posture. How often have you seen doctors who are looking to computer screens and appear busy as the patient comes and they begin questioning, look at the screens itself before looking at the patient once. Yeah, this is a very common sight. And I understand that we are busy. It's not that we are not busy, but it takes hardly a fraction of a second to look away from your computer and look at your patient and give them a smile. Or simple things like going down to their eye level, especially when talking to children. These are simple things, small things, but they indicate respect and communicate your genuine interest in being here with the patient. So let's look at some helpful strategies that you can use when you communicate, right? First is open-ended questions, right? That's your best friend. What I mean by that, asking, are you in pain today versus how are you doing today? Is there a difference? What do you think? Are you in pain today? And how are you doing today? It's not the same thing, right? The first one, when you say, are you in pain today, limits the answers to yes or no. The second one invites the patient to open up and to express. Open-ended questions give you more information. It lets the patient direct the conversation to what they feel is a priority concern for them. And that freedom is important for us as well, because using out an information that we did not inquire about. So make sure you begin with open-ended questions. Second is summarizing and checking for patient's understanding. Is there a discrepancy between what I intended to convey and what the patient perceived? It is also useful to summarize the discussion so as to reinforce joint decision making. It also gives the patient a chance to get everything in a nutshell in case they have felt information overload. Let's say, for example, you could say something like, I just want to go over what we've been talking about so that we are on the same page. Yeah. So whenever you are ending, you could say something like, what questions do you have? Is there something you would like to know more about? Followed by a summary. I would like to go through the key points of all that we spoke about from our discussion today. And of course, arrange for a follow-up. Say that you'll meet again. And in between also, if they think of something that they want to discuss, any questions about what we spoke, please note them down and we can speak about it in our next meeting, right? Thirdly, avoid jargon and avoid overload. When you're giving information, don't use heavy technical medical terms. Keep it simple. Remember that our goal is that the patient understands what we are saying. And don't give too much information at a time. Encourage them to ask doubts and ask their questions, but at the same time, respect the patient's choice about the extent to which they want to know. It is not compulsory that you tell them everything, even when they explicitly say. Most such discussions will have a heavy involvement of an emotional component. Make sure you don't avoid facing them. Be present mindfully. What I mean by mindfully, in the here and now and without judgment. And listen actively. Acknowledge their feelings. Let them know that it's okay to feel what they feel and that it is also natural in the given context. Do not invalidate. Let's say, for example, saying something like, there is nothing to be afraid of is a strict no-no. Next tip, which is also very important, is be okay with silences. They help. Learn to not be uncomfortable with these silences. Let the patient take their time to process. That's very important. So please don't fill the silence with pointless communication. I say pointless because it is often not heard or received, what we are saying. And even if it is, then just distracted the patient from actually processing the information or processing their emotions and organizing their thoughts before they responded. So don't interrupt that process, especially when we have given a bad news or when we have, given some major, communicated something major, right? Give them space, let that silence be there. When we are delivering bad news, we can definitely do it with sensitivity. So have a balance between hope and truth. So then either hope or truth, we can find a balance between two. So let's say, for example, saying like we don't have to say something like, we can't do anything more. There's no cure for your disease. There is no point in continuing to stay in the hospital, only waste your money. We don't need to say that. But we also need to say, if you believe in faith, you will surely recover. Instead, we can definitely say something like, sorry, I'm afraid there is no more treatment available as a cure for disease. We can definitely keep you as comfortable as possible with medicines and regular monitoring, and we are here for you always. Right? We need not be always choose between hope and death. Next is confidentiality. Of course, reassure the patient that sensitive details that they might not want to.
We have lost Mukta, isn't it, Shripriya?
Hello.
Hello?
I have joined
you have
again.
come back.
I hope
Yes.
I'm audible.
Thank you. That's what
Yes.
happens is
Yes.
in between, Mukta,
Yeah.
on
Yes.
and off, your voice, like
Yeah.
it is okay. On and off, we do have some breaks.
Okay.
So now it's good.
Yeah, and if there is too much breakage of voice, what I can do is I can, of course, later on just record this and send it probably just an audio or something. If too much, yes, we had reached respecting the patient's boundaries, right? So as I said, respect the patient's boundaries about what they want to tell, what they do not want to tell, what they want to discuss, what they don't want to discuss. And always inquire further, especially in problem behaviors. Let's say the patient is not eating, there is social withdrawal, there is non-compliance to medication. Usually there is a deeper underlying problem. So don't assume or don't whatever is happening. So to sum all these things up, you start with open-ended questions. Let them lead the way. You speak simply, adhere to the core principles, and end all that you discussed. Make sure the doubts are answered. Follow up. Yes, I hope I was clear up till now. And okay, we have a little time. All right. So moving on. Next slide, please. Yes. So we've seen what to do. क्या करना है वो तो देख लिया ना. So let's see what not to do, because that is equally important. Do no harm. That's the first thing, right? So firstly, do not moralize. Do not philosophize. Don't say stuff like this life is a gift by God. How can you even think of dying and stuff like that? Please don't do that. Avoid comparison. Don't say stuff like, look at that patient. That patient is in so much pain, more pain than you are in. Do you see that patient crying and cribbing? Why are you doing that? There are so many others in a worse condition than you are. Don't do that. Don't compare. Don't use meaningless statements that can stop further communication, especially saying things like there is nothing to be afraid of. You know that there is a lot to be afraid of. Don't say there is nothing to be afraid of. Don't use jargons. Yes, as I've already mentioned. Let's say, for example, I tell my patient, the carcinoma is quite radio sensitive, which increases chances of remission. My patient didn't understand anything, right? So don't do that. Don't give false reassurance. And okay, there is one more issue with this reassurance. Many of you had given said that the answer to that quiz was, don't worry, everything will be all right. One problem with reassurance is it can feel invalidating at times. It can feel like we're dismissing their concerns and we're saying that, oh, that is nothing. Yeah. So don't just reassure, always validate first, then reassure, right? And don't over reassure also. Don't, as I said again, don't make assumptions. Always ask what made them do something or ask something. Don't be condescending. Don't have that attitude of, do you know more than the doctor? Let us decide. Don't have that condescending attitude. Don't force your beliefs on the patient. Yes, it might be spiritual beliefs or anything else, but don't force them on the patient. don't be all sympathetic, like don't have that poor you pitying sort of a tone of voice and all of that. Don't use inappropriate humor. Now, this happens rarely, but it does happen at times. Like saying stuff like, oh, so you want your final visa, is it? Please don't. Also, when I said, be honest, don't also like it shouldn't be thoughtless honesty. It's not just what you say, but also how and when you say it. And of course, lies. Lies is a strict no, it breaks trust, right? So let's just basically put things in a sequence so that it's easier to put into practice when you actually start applying all these things. Okay. Next slide, please. The previous one. Oh, okay. I think a slide is missing. I don't know, but anyways, I'll just continue without the slide. That's okay, not an issue. So yeah, as I said, let's just put things in a sequence. First thing to do is build a relationship. Okay, set the scene. You need the time and privacy. Preferably, you could be sitting down at eye level, not too close to invade private space, but close enough to lean forward and touch the patient if the need arises. Convey empathy with your expression and with statements like, I see that you're very worried. Basically, the important thing is to convey that you care. That's the first step, is to build a relationship. The second step is to open that discussion. Acknowledge their feelings. It could be feelings of pain and loss. Acknowledgement of suffering basically makes the patient feel that they are understood, unlike dismissal of these emotions. Listen actively. Yeah, active listening involves eye contact, appropriate facial expressions, empathy, body language, and verbal responses, of course. Right? So it also involves encouraging the patient by repeating, maybe, paraphrasing, repeating the last few words and stuff like that. Listen to what is said, but also to what is not said, specifically their facial expressions and body language, which might indicate suffering. So that's the second thing. Open the discussion after you've built the relationship. After which you start gathering information. You explore and you find the patient's level of understanding. What do they already know? How much do they want to know? Use open-ended questions, statements which invite responses, like what worries you the most? What do you think might be the problem? Understand the patient's perspective. What do they feel about it? What questions do they have? At this stage, be prepared for an emotional reaction. There could be sobbing, there could be anger, there could be silence, despair, a lot of things. Be prepared for it. All right. And sometimes you might also need to facilitate sharing. You might have to say stuff like, could you tell me what are your thoughts right now? How are you feeling right now when you heard this? After this, you start sharing information, right? That's the fifth stage, where the patient will decide the agenda for further discussion. What she considers or he considers the most important must be discussed at that stage. If they want to postpone discussion about that should be allowed within a reasonable time frame. Of course, the patient has a right to know everything, but they don't have a duty to know everything. So confirm what they want to know. Use common conversational language when you share information, and keep checking understanding at every stage, right? Next, reach agreement on problems and plans. Summarize the problems that were brought out, suggest a course of action, answer their questions, and arrive at a course of action that's acceptable to the patient, making it clear that it's not an ironclad contract. The plans are negotiable. And lastly, close the discussion and do it sensitively. Don't do it abruptly. Always review and summarize before you finish, and leave the door open to talk again. Right? So, 7 things in total. Build a relationship, open the discussion, gather information, understand the patient's perspective, share information, arrive at an agreement on problems and plans, and close the discussion, right? So, after all this, I hope there was no information overload. But after all of this, is anybody wondering what happened to S? My patient whom we visited at the start of the session. And what did I do when I actually met her? Well, I did exactly all of this, right? So all these 7 steps, I built a rapport. I introduced myself and I told her I'd come to speak to her about her illness and to know how she was doing. The moment she realized I was not here with an agenda, but with genuine concern about how she was coping, she opened up. The first thing the lady told me was she had heard the word kidney for the first time in her life. She had no clue what it did. Basically, when she was told her kidney isn't functioning, it sounded alien to her. It had no meaning. However, she sensed the seriousness in the atmosphere. She came home and she Googled kidney with the help of her son. So she understood a little bit about what it was. Now, the problem was people who could communicate the right information were mum. But there was no shortage of people, relatives, friends, well-wishers with baseless information who had no qualms or questions about is this true and how will it impact her. So she heard all kinds of stories about how this means she'll die, all sorts of scary, tragic stories filled with negativity and despair. She did her best not to listen to them, right? But the problem was, in an attempt to do that, she overcompensated by denying the seriousness of what has happened. She was tired of the 30 pills she had to swallow every day. She had tons of questions and no one to answer them. So when we met and when she actually opened up, we started right at the beginning with what a kidney is and what it does. Most importantly, that there are two of those and we can function with one. And that she is not asking her parents to sacrifice their lives for her by asking them to give her their kidney. That was the biggest relief she got out of that entire session. She cried and she let things out and she asked all the questions and expressed her needs of how uncertainty brings fear, how anxious and worried she is for her son, who has grown up too soon in this ordeal. And if she were to know what was going to happen and what the doctors were doing, she would be much better prepared. She knew what she wanted, clear communication, knowing what had happened to her, knowing what was being done to her, knowing what could happen to her. Simple needs. At the end of the first session, I did tell her that she was free to get in touch if at all she had any doubts at a later point as well. After the first consultation itself, she became much more cheerful. She started expressing more openly to everyone. Communication at home with her husband improved. We began meeting her son periodically as well, which eased a big load off her shoulders. She began actively working towards treatment, taking the initiative to tell her family about transplant and related issues, which she had not done until then because she didn't know what to tell them. And of course, at that stage also again, she did take our help. I met her family along with her and her husband. We discussed what treatment options were available along with the doctor. Currently, her father as well as her mother, both of them luckily in excellent health, have both come forward as donors. After discussions within the family, the further procedures are like in the pipeline, on the way. She is taking her medications. There were also, we had to start dialysis as well. She's undergoing that, and basically she's doing all of that with courage and hope in her heart. S is fine. Thank you. Thank you so much. And I hope, I think I've managed the time somehow, but I hope I've not rushed a lot through it. Is there
Thank
any
you.
questions, any doubts? Yeah. Yes.
Thank you, Mukta. See, like thing is that we like this is an important thing, like because when we so far when we do some case discussions, they have had some queries. So
Yeah.
I've been telling them I don't want to ruin the importance of the communication session, so I won't tell everything. That's what I've been telling them.
Okay.
So really, thank you very much.
Okay.
And important,
Thank you.
you have put forth exactly. I used to tell them, you will know what are the do's and don'ts. So you've given them in a plate. So,
okay,
and
yes.
just as you mentioned, this non-verbal communication, I'm going to give them a small clue. See, leave alone patient, okay? You take your house, your child, your friend. How you behave or how you do is what you get, especially with children. I'm just going to tell one nice joke on. You tell your child to do something, and what they say, Mom, you were so harsh. If you had told me quite softly, I would have done it. You raised your voice, I'm not doing it. You get that or not? If someone doesn't get it, okay, I do accept, but touch your heart and say, how many of you have not heard this from your children? So if it happens on a daily basis with something like that, so non-verbal communication has a very big role, both ways, in good and bad. So why not, like, see, our lifestyle and things are so busy. I wouldn't say like 50 patients, 100 patients you see, and you have to finish that day. You have to see, means you have to see, nobody else is going to come and do that. Or and every patient who has come needs to be seen. They can't come all the way from somewhere and then you don't see them. That's not also not right. So we have to find the balance. So which needs some extra time. You have to take time and communicate. And by communicating properly, and the case what she mentioned, see, so many may not know. Many things will be Greek and Latin. That's why we say don't use jargons. Use simple words, and then on and off, ask them whether they understand or agree. And especially with palliative care, see, sensitive issues these are, okay? And serious issues, both. See, either life-threatening or life-limiting, okay? It could be either. Life-threatening is one and life-limiting. I have been doing something all along and I find it difficult to do from next day. Who will not be worried? Anyone on earth, any human being will be worried only. So that's why whenever you see any chronic patient, oh, then you say, I can't do that. We say, no, you cannot do it that way. We will tell them how you can do the same thing in a different way. That's all. So just by communicating, you can get wonders done. So that is an important thing. Once you do know the do's and don'ts, it will help you and will make a ocean of difference. So, and a smile takes you a mile. So you have to practice. You have to slowly start. Smile will keep you also young. When you smile, you use less muscles. When you frown or cry, you use more muscles. So you want to be nice and young, smile more. So there are so many things like that. So thank you very much, Mukta. Will anybody else? See, one thing I thought, like that 4 choices what you gave, no? Anyone would like to differ with that now? We can ask them, what is the, and somebody has raised, Chidananda doctor, he has raised his hand. He can unmute and speak. And then the rest also, if you want to discuss those 4 choices, Mukta, that's something really very important one. If they want you to go through, that will be nice, dear, please.
Now, another thing what I felt is very, especially when you're communicating with the patient or the families, especially when you're counseling them for a long-term decision or anything. Don't try to be preoccupied with this. Is a common what we see is people busy with their mobile phone or working on the laptop or the system. They're coming talking, but they're doing something else here. That, I think, that breaks the confidence what the patient or the family has in you, and also feels that what you're talking, you're just trying to finish off the issue rather than trying to have a heart-to-heart talk with them. This is what I think. There is one more common error which I notice when people keep talking to the patient or the families, especially when you want to break a bad news or when we want to get them involved in decision making regarding the further course of management of these patients. This is what do you say, madam?
Totally true. Yeah, that's what she also mentioned. Mukta, go ahead.
Yeah, that's what I was saying. Absolutely true, sir. That that's the first thing, first and foremost. Pay attention there with the person. Don't be preoccupied with other things. Anybody else who wants to add something?
Thank you.
Anyone else? I think, ma'am, we also have a case presentation.
Radha ma'am, you are muted.
Sorry, we do have a case presentation. And I just thought those 4 choices, what you had given in that quiz, Mukta, was very important because it had all the do's and don'ts in it. See, just reassuring was one thing, okay? And then telling, oh, you have got it this young. That again, who are I or me to say that? So that's why I thought those 4 stems were very, very appropriate.
Yeah.
And D was the most, see, there you're being empathetic and telling them, okay, it is difficult. So how can we manage? We can see what are the ways and means of doing it. So that is what, so I felt that that is really do's and don'ts were there. And also the answer was also there. Okay, we can go.
Thank you.
Nobody, no, because nobody else will go with the case presentation.
Yeah. Good evening, ma'am. Good evening, Palem India, and good evening, Radha ma'am and Mukta ma'am. I'm not able to see my slides.
So that's what. Are you going to be presenting or Palem doing it?
Ma'am, I've sent
We will be presenting. The screen got shared, but then something's happened. I don't know what is happening today. Just give me a
So
moment.
Palem will share.
Yes.
In a
You
minute.
share.
Regarding reassurance also, I want to just clarify that sometimes the patient keeps on asking that, are we going to be fine? Is everything will be okay? So keep on saying we have to be patient only. That is the only answer. Because I told one of my patients that, am I audible?
Yes, ma'am.
Yes, you are audible. Go ahead. We can, you do your presentation. That is something has to be said appropriately. You have to find the right time. You go ahead and say what you were telling Dr. Kamachi.
Yes, ma'am, because one of my patient, I told that everything will be fine. You'll be okay soon. And this you'll be start walking. That was a patient has a neurological disability. And the patient was happy for a day, two, but afterwards, like after a month, she complained me that you always give me boost, but the things are not in the right way. The things, my disability has not gone. And that really hit me hard. That
see there, that is where today, what did she say? Don't give false reassurance. A neurological patient, see, that's where you have to be kind, but at the same time, you're not, that is your, is there, your medical knowledge should give you, you have to have reality and the compassion, everything balanced well. Okay, if it's a neurological irreversible damage, how will it become all right? So there, what you have to say is, that is where your clinical acumen, clinical expertise comes to play. Okay, this way may not be possible. What are the other ways? That is the way forward. See, that is what she said. Don't give false reassurance. Okay, compassion and see, that's what sometimes keeping silent. You said being patient, going with the patient and making them understand. That's why don't give false reassurance. That is one of the things she said. That was also one of the options in that quiz with 4 options. Okay, so that is what you will all learn, that clinical knowledge, clinical expertise gives you the knowledge. So as I keep telling, it's a medical decision. So that your medical knowledge and skill work with you with good communication to get the best for the patient. Okay, you go ahead with the presentation and then Mukta will also add on to more things as we go ahead. Okay, no worries, Dr. Kamaksha. You go ahead and then we will come back to that.
Yes, I'm presenting a case of a 60-year-old male who presented to us with a carcinoma of esophagus. He had a difficulty in swallowing solids since 2 months and a loss of appetite since 2 months. There was a significant weight loss, and he also complained of backache since the past 1 month. Now, the history of present illness, it dates back to 2 months when the patient had difficulty in swallowing solid. This was progressively increasing, and now he could only digest semi-solids, and that too in small quantity. There was also significant loss of appetite, and patient lost approximately 8 kilos of weight in the last 2 months. History of pain in the back, which was more concentrated in the right flank area, was present. The pain was dull in nature, but it was relieved by taking medication. There was no postural variation of the pain, and it was not associated with nausea or vomiting. There was no significant past history. The patient, as per personal history, he was a social drinker and a non-smoker. He was hypertensive since 15 years, and there was no history of diabetes, bronchial asthma, thyroid disease, or any coronary artery disease or tuberculosis in the past. In family history, there was no significant family history, but he was married and had 2 sons who were also married. Now, in journal physical examination, patient was cooperative, well-oriented to time, place, and person, but he was anxious. His pulse was 90 beats per minute. It was regular and good volume. BP 106/77, and her breath holding time, which we assess, is 26 seconds, as this patient was to be taken up for surgery. Patient weighed 70 kgs and height was 5 feet 7 inches. Airway examination, spine were normal. There was no significant abnormality detected in any of the systemic examination, like chest, CVS, respiratory, CNS were normal. Abdomen was scaphoid with normal temperature. There was no tenderness, and liver span was 5 centimeters. There was no visible pulsation or scar marks. We got the significant investigations of the patient, which include, after getting the routine investigations, these include echocardiography and pulmonary function tests. In echocardiography, it showed a left ventricular ejection fraction of 50% with a trivial mitral regurgitation, and pulmonary function test revealed minimal restrictive pattern with a saturation of 97%. Our treatment plan was that the patient was posted for esophagectomy, that was Ivor-Lewis procedure, under general endotracheal anesthesia after taking informed high-risk consent from the family. Now here the psychosocial aspects arise. The patient and his whole family were very anxious because it was a major surgery which was undertaking. They were not prepared for the surgery. The moment they were explained about the risk of the surgery by the anesthesiologist, they got agitated and refused to undergo the procedure. As one of the anesthesiologists, they told them that during anesthesia, we make the patient put on a ventilator. The patient was full of anger and he was disturbed and he was not willing to talk. Then I sat next to the patient, introduced myself to him and listened patiently to all his problems. He was disturbed as one of his distant relative was given anesthesia for cardiac bypass surgery, and as a protocol, he was put on a ventilator, but he never came out of the ventilator. The patient's apprehension was that when he will be given anesthesia, he will be put on a ventilator and he may never come out of it. Deal with this fear and anxiety was a big task, as all I need was to win his trust, make him comfortable about the whole procedure, and allay not only his anxiety, but also his whole family's anxiety. So he was also on medications, telmisartan for his hypertension, then pantoprazole, alprazolam, and aspirin. Now the main concerns were to give psychological and emotional support to the patient, to build up his trust in anesthesia and surgery, to allay his anxiety, to communicate everything in a truthful and an honest way, to develop rapport with the family and convince them in a way by which they can be supportive to the anesthesiologist. So the summary of this case is that this patient presented the 60 years old patient presented with CA esophagus and it was posted for Ivalois esophagectomy under general anesthesia. Patient was very anxious and was not willing to undergo procedure under anesthesia as he does not want to be put on a ventilator, which is an integral part of anesthesia. Listening to the patient's apprehensions is very important, and this helped the patient. Being truthful in a way which is beneficial for the patient helps a lot. Showing the whole procedure with the help of videos and developing a rapport with the near and dear ones of the patient is very important. Non-verbal communication, which is seen through our actions, also helped a lot in this case. A doctor should not give the information, should not just give the information, and also sees how it is being perceived by the patient. Thank you. So the discussion point is that, do we ever listen to our patients thoroughly? Are we very busy in our routines that we hardly see the emotional aspect of the patient and his family? Compassionate listening is the key to success. Do we need to hide things from the patient and or explain them in a way which does not make them more apprehensive? Being an anesthesiologist, as I am an anesthesiologist, we tend to meet patient just once during the pre-operative period. Is it feasible to explain all the things in a single meeting and gain their trust? For a good communication, our peace of mind also helps. Calm tone of our voice and a healing touch, our faith in ourselves and our work is very important for an excellent outcome. Thank you, ma'am.
Thank you, Dr. Kamakshi. Yes, like it takes a lot. And once you start doing it as a practice, it'll become like second nature. Only thing, trying to know what all has to be done. That is the important thing. But once you know that time is not a barrier which stops you from doing it, I would say. Cultivating some good habits and knowing, like especially the do's and don'ts is what is important. Thank you very much for bringing this case. And let's go and see what are the main concerns. Do we ever listen to our patients thoroughly? So like, this is what Mukta has told us all through the day. So what is that? I think you can answer, and then the rest, the whole team also can answer. What do you feel? Do you listen to your patients thoroughly?
Ma'am, to be sincere about it, if the patients are patients, I do listen to them sincerely, thoroughly. But some patients, I am in hurry, because if the number of patients are a lot, so some are missed and some are given attention.
No, that is where, no, like, see, I give this example only, 40, 50 patients to be seen. At the same time, you have to prioritize.
Yes,
for example, as anesthetist, ASA 4 patient and ASA 1 patient, are they the same?
No, ma'am.
So you spend a lot of chit-chatting with ASA 1. I'm just trying to give you examples so that you yourself will answer all your questions at the end of the thing. ASA 1 patient, ASA 4 patient. So whom you will have to spend a little bit more time?
Ma'am, with ASA 1, in convincing the patient, I'll be spending more time, and in ASA 4 patients, I'll be busy with all the reports and I'll be busy in managing.
So that is why I'm telling. Yeah, both you have to do the job in 5 minutes, but it is totally different. Okay, so for that only I brought up this ASA 1 and ASA 4, because you will know which is going to be a challenge for you. At the same time, just because it's ASA 4, you don't get worked up and do everything in a hurry, or I have to do this, I don't. So that is where you have to manage your time. You have to give more, either you give your time a little bit more, get all information before, or go ahead and see. There are ways and means of handling it. Okay, so that is important. So you have to prioritize, and patient doesn't get compromised at any cost. Okay, that is how we have to prioritizing and knowing where, what to do, when to do, all that is equally important. And as you have listened all day, know that where how you listen to patients. That is important. Like, I think the 1 and 2, we will combinedly take. The second one is, are we very busy in our routines that we hardly see the emotional aspect of the patient and family? That's what you've been telling. They said, don't look at the screen, give importance, give respect. So all that, all your do's and don'ts, you have to remember clearly. I will ask Mukta to also share your views, dear.
My many questions got answered.
I also wanted to add one thing.
Go ahead, Mukta.
Yeah, when it comes to listening to our patients thoroughly, I also had one thing to add. Speaking of a psychological aspect, we all have patients that we look forward to meeting, and we all have patients whom we dread meeting.
Exactly.
So we have all these so-called good patients and bad patients, and listening to the bad patients is what we are bad at. Like, we know that they're going to grumble, we know they're going to complain, we know they're going to be angry. So that is where this whole unconditional positive regard comes in, where that should not be the criteria for whether I'm listening to my patient or not. That should not depend on whether my patient is up to my liking or not up to my liking.
You like or not, no, like, see, all through my work, like I have worked in government service, okay? All life only government service. I've never done private work. So always workload will be more only. So we were taught, you anyhow, you have to do it. So you will learn a method to do everything. So even someone who doesn't like, you have to talk to them and go ahead and move ahead and do the patient, do whatever is needed for the patient. So as she said, even the patient whom you don't want to see or you want to avoid, you have to see. So you have to find, okay, what is that I'm going to do so that we will have a better conversation. That's what open-ended conversation, not being prejudiced, not anticipating this, even if something, not anticipating any regard or appreciation, anything like that, but still go ahead and do. That's what is unconditional. So that is important when you see. So that will help you. All of us will develop that habit as we move forward. And maybe slowly you start incorporating communication skills also into your routine, which will be happy. Because see, again, when you can't be listening to their own personal family worries and troubles. That you can do when you set aside a time separately. Okay, so that also is important. Where, when, how, and how long is the time allowed. So if you think that extra time is needed, you get the patient and family again. That's why some of these difficult communication will not happen in one setting. I will ask Mukta, for example, the patient, what she saw, she would have taken 1 or 2 meetings, that lady patient with the kidney issue.
Yes, ma'am, absolutely.
So yes, that's another thing. Go ahead, Mukta.
Yes, absolutely. Yeah. No, what you said, ma'am, is absolutely true. That, the problem is we're always in a hurry and we try to rush the patient through that process as well, but that's not going to happen. So, as I said, I also mentioned in the presentation, within a reasonable time frame, we can, we can allow certain discussions to be postponed, certain discussions to be given more time. But again, that is going to be your clinical. That is where your expertise will come. Like, which ones are urgent and immediate, which ones will take more time, which ones need to be given more time, all of that.
And then, thank you, Mukta. And then the next question, do we need to hide things from the patient or explain them in a way which does not make them more apprehensive? Brings her own query, like before starting the presentation, what she had, I think we'll combine those two and then you could answer for that, Mukta, please.
Yes. First of all, that's a strict no. Please don't do that. Because it's your patient's right to, we can't make decisions for their lives. It's for them to do. And when we speak of reassuring, falsely reassuring at times, I think many a times it is more to do with our comfort and our discomfort. Right? So let's say, for example, telling your patient that they might not be able to work like they did previously, and they might have to live with patients, is going to do an emotional reaction from them, which at times is stressing to witness for us, right? So our job is to be like at that point going to be to sit with them, but to handhold and not just immediately jump in. Of course, we'll reach a point where we'll speak about what to do next, given the limitations. But you can't keep reassuring and avoid that discussion. You'll have to open that discussion and be there when that emotional reaction comes. See, many a times we hide things and we keep reassuring. We don't want to face that. As you said, it might make them more apprehensive, more anxious, more uncooperative, and we don't want to face that. But that's not really right on our part to do.
But ma'am, you said a sentence now that it's the right of the patient to know, but it's not their duty to, it's not our duty to tell everything. That was the right sentence.
That is where, I will also say, and then Mukta, see, you have to understand both the phrases very well. Okay. What is their right to know and what is your duty? Okay. Coming there, okay, like you have to, maybe the first day when you're seeing the patient is crying, okay? And because they themselves have not understood, they're crying, their emotion is overtaking the actual their understanding ability. Okay, in that situation, what you do, you have to ask. There, she said, no, you ask and make sure, have they understood what their issue is? He or she may not know what is her neurological problem in the first place, like this lady not knowing what kidney is. Is there assurance that your patient knows what her neurological problem is his or her?
No.
That is where the answer comes. Okay, it is just figuring out. So you should adhere to your duty, and they have the right to know. So finding the right balance. So this will not happen in one meeting. So yes, first time you ask her, do you know what your neurological? First thing she may say, she said, I know something. Then you spend time. That you do separately, not in your time when you have to do or deal with all the other cases, everything. So you tell them, no, I can talk to you, explain to you, come another time or stay back. Once I finish all my patients, I will sit and talk to you. Then explain. Once you explain, then you tell, go home, think about it, come back with your queries. Because when you're telling everything, oh, it is all too much, so I can't absorb everything. So that time itself, you give suggestions or answers, it won't work. Tell them to go home, come back, think about it, come back again in 1 or 2 days with your queries. Then you say, so that is the better way. If you, no one will protect you if you give false reassurance. That is where you have to know what your duty is. Okay, so that both are important. How much you agree with me, or still you, what is your query? Go ahead. Mukta, you can also add on, please.
No, ma'am, I understood.
Yeah.
Key to this thing is to give time to the patient. Giving time to the patient and making them understand what we have told. That is very important. A lot of information can sometimes be dangerous. I understood that if I told, if I tell her something, then and I give him time that he can or she can think about it, and later he or she will be in a better way. And if I am spending time, so I got the answer. And thank you so much. Timing is the key.
Go ahead, Mukta, you wanted to say something.
Yeah, I also feel, ma'am. Yeah, I also feel that with the upcoming communication session where we speak about breaking the bad news, I think then also this will become a lot more clearer.
Exactly. That's
Because
what. So
like when we say breaking the bad news, it's not only about death.
No,
It's
no,
all
no. So that's
things
what. So
also.
everything, appropriateness, everything.
Yeah,
Totally
yeah.
true, Mukta. In that only, that many more things also, patient, family, everything will be answered in those in the next session when we will be dealing with all those things. Tricky bits of communication. Now we are telling what are the easy bits of communication. So that is what it is. And then the other thing, what were
That also got answered. That single
that's what all things single meaning, that also. Okay, that's all. See, main thing. Sripriya, we can come out of this screen. Sripriya, please. So it is like, see, communication has to be given importance as part and parcel of our routine. And then if not also, see, many times you would have learned it as you went by, learned it the hard way, I would say. But never mind, never late than ever. So that is the way to take it and move forward, so that you learn something and you put it into practice and be able to get the best out of it. Anybody wants to add on anything? Or any other burning queries someone wants to ask? In that case, a big thank you to Mukta, and I will pass it on to Sripriya or Anup.
Thank you, Mukta ma'am, for your wonderful presentation. Thank you, Radha ma'am, for your faculty in law. And thank you everyone for joining us. This is Anup signing off from IPSACO. Thank you. Bye.